my plan for this section, Dr. Tung asked me to cover his talk. In this presentation, I would share to you some concept in design of GOV lenses and how I started doing my myopia control and autokeratology in my clinic. And I practiced for the last 7 years in autokeratology, and I have my own clinic, and I train many my colleagues practice autokeratology as well. So I think all of you in this hall will have many experience on the contact lens practice. I'm cornea surgeon, so I just see the ocular surface, and I set up the clinical process model to run the autokeratology application in my country. So there are many sections over the world talking about myopia control and myopia progression. So we are in BIPOC section. BIPOC first meeting in Hanoi in 2018, and last year in India. So I hope next year we will have a meeting in India as well. You know that the prevalence of in myopia over the world is increasing. Especially they concern about rate of high myopia. And they also said that younger myope progressed faster. So that's why for the last 10 years, we are talking many options about many options to do myopia control, like lifestyle changing, autok, multifocal contact lens, multifocal glasses, and medication, for example, atropine. So just I take a look about, we have just have a review. They said that autokeratology is the most effective method of myopia control, followed by pharmaceutical approach and contact lens, soft contact lens also. And they also found that in Asia, the highest rate of eye care practitioner concerned about myopia control, and they also include the myopia control in their practice. So as Dr. Monica said, the functioning of fovea and ocular axial development, it is not related. It responsibility by the peripheral retina. So in 2013, Earl Smith said that they suggest that the strategy to slow myopia progression, we have to extend the optical treatment zone in contact lens application. So by that term, they said they recognize that autok is the best way of myopia control. As Monica explained to us, so peripheral defocus, that is the main cause of myopia progression. So in the review, they also said, and many public in literature said that atropine maybe is it is easily application in our clinic. Just put the drop, but it has many side effects, especially with the high dose, high concentration, and other atropine is one of it has a dose dependent manner. So that was, and still have many questions about myopia control by atropine, and they need more study with the last sample size, and especially the quality of return of the follow-up with the many patients. They cannot follow the drop with the doctor, so the missing data is there. So that's why we don't have enough evidence of atropine eye drop. So I came to know about myopia control in 2010, and I joined in the Academy Autokeratology in America, and I just opened my own clinic for myopia control in 2013. And with this clinic, I only focused on the myopia control, consent, give advice to all the refractive error. And I met Dr. Tung. Dr. Tung, he's practice in cornea, in contact lens, and he's a designer of GOV system. He's practice in US and Taipei. He's come up with the special lens design in AutoK with the idea relative curve. He said that if you want to reduce, you want to correct much myopia, so you have to create steep mid-periphery ring. So he also he also modified the Mundellin formula. He said that the epithelium thickness is only 20 microns. So if you follow Mundellin formula, it means you only concerned about the push force directly on the cornea. So you can do that better if you make the mid periphery more curved. So from that idea, the treatment zone will be increased, and also much more myopia can correct. And also one of other idea of his Dr. Tung, he said that you won't order a pair of shoes based on the photo of your feet. That's why and he also said that topography is not really useful to detect all the cornea surface. And he made the trial lancet. Each trial lancet has the 31 lenses, and they have a different size. Small size of trial lancet maybe have 11, 12, 11, and it based on the K code also. As you know, The autokeratology in will make the difference on the cornea epithelium layer only. Here you can see in OCT image, and with the GOV design you can correct astigmatism without toric design. In high myope, you also have to look at the lower lid. And in my country, we don't have a optometry school, and the contact lens also don't have a program in university, medical university in ophthalmology. So all of this is make us very difficult to handle all the contact lens cases. And in my country, almost a family came to me because they concerned about myopia progression. And at that time, I started doing autokeratology, almost the first doctor in Vietnam. I have to put a lot of effort to train everybody, and I have to train my staff. So by that way, and I have to get somebody other not in the medical side to make everybody to make the autokeratology using is the safe and efficacy. Also, we have to concern about infectious keratitis. And after some time, I make my protocol. For example, in patient selection, I will base on 3 factors. First is the grade of myopia. Second is the age. Third is the family income. If you want to get more money, so you do in all case, that is not good idea. So I base on this factor. And I also think of 3 steps in clinical process model for autocay using. First, prescribe. Maybe this first step we will do. And the second step, care and follow-up, we will keep to our optometrist or medical patient care. They will do that. And I want to do, I create standardized process of prescribing and maintaining autokeratology and early diagnosis of ocular surface disorder. And third is the involvement of other health workers in autocay patient care. To make it, first it is safe. That is the first criteria. Safety, efficacy, and reduce complication rate. And in my country, my colleague also do many way to prescribe the autokeratology parameter, but I interested in fitting. All of the case, I think the fitting is very important. The fitting will help you see how the lens sitting on your cornea, and the factor like eyelid, limbal structure, and HVID. All these factors is contribute to the lens center well. So I will make a video for each fitting. And especially in this design, the size control is very important, very important. You have to make the fitting and then you adjust the size based on the size of trial lens. So you can see some photo. It show in the high myopia. Sometimes you can see this happen. The scleral show this. So it also affected to the lens support. So if you don't recognize this, you may adjust the lens size or K-code of the lens is wrong, in the wrong way. And you have to observe how the lens is moving when the eyes blinking. So some of things I think it is keep our fitting safe. Like all of the case, I use GOV lenses with fitting with a trial lens set, and I do size control. K-code of the lens, it means K average, and we are doctor. We will see and we will take care of the reading fluorescent pattern, and we will decide lens parameter based on the fluorescent pattern, and we will take care of ocular surface, follow up, and close watch lens and eye care. We will train our staff to do this. And be careful with the family, low income, poor condition of life. Explain before fitting and make consent. Size control, and some cases with Y-to-Y astigmatism and high myopia with high astigmatism is difficult cases. And this is some of my data. You see, almost of them is this. If the patient have low myopia, they can get the good vision after 7 nights wearing. And since now I have a very long follow-up with autokeratology, myopia with astigmatism is almost 80%, and the rate of withdrawal from AutoK in my patient is around 8%. And they have dry eye keratitis, answer keratitis also, because almost this thing you will see, especially in the first few months of using AutoK. See, you can see all of this. And there are 3 cases with answer, and almost all of cases it come late, after 3 or 4 days, and some of others they come immediately at the first day, have a symptom, so it will be resolved. And so now this is a clinical process model we are doing now. And also I train to other doctor also, where they just keep this model. So first, step 1, prescribe. And step 2, care. I will make all the brochure to guide how to insert and remove lenses. And I make a video to train and to give the user. And they can watch and follow. At the step 3, that is a follow-up. And the follow-up will be in the first 3 months, after 1 week, after 1 month, 2 months, and when they finish 3 months, the first 3 months, I will ask them regularly, every 2 or 3 months, come for checkup. And in when the checkup, we will check the ocular surface, corneal surface, and I will ask my staff have to recheck all the protocol and using how the lens care, how they are doing at home, and insert and remove technique also. Yeah. Whenever they have red eyes, for example, or photophobia, they have to contact to my staff, patient care, and they, based on that, they may give them some advice to manage those symptoms. And they should be as soon as possible, they inform to patient care person in our clinic. So this is one of my patients. She is 7 years old. She is doing by herself. Thank you.
So, any question? That question is to me, ma'am.
What is cost? Trial lenses, 1,000 US dollar. 31 lenses, and they have I bought 4 trial lenses, small size and big size, and each small size I have 2 sets. One is a -3 and one is -7. -7 lens set we use for the high myopia, and -3 for low myopia.
Okay. How much is the diameter of the central flat zone when you put these lenses on the eye?
What's its diameter?
Of the flat zone,
Flat zone.
the dark zone which is there on the cornea.
Central.
Yeah.
How much is that?
They have a lens set here. I show you.
The topography which you can see that 21 slide number
Yeah.
21, it looks very small.
Yeah.
The
Yeah.
a slide before that.
Yeah.
And after that,
Oh.
after that. Next. One more. I think there was a topography for quad map.
Topography.
Yeah. So there it shows where it's to be very flat, 2 millimeter or 3 millimeter central zone.
Yeah. Yeah.
It's more than that.
Yeah. With the high myopia, first we have to first fitting. Maybe with the high myopia, we have to do 2 steps. First, we do regularly, like K code is a K average, and then we adjust the lens size properly, And the second step, we will reduce the K-code. It means a sagittal of lenses to make the treatment zone is bigger. Yeah, that's only for the high myopia. Yeah.
I have one question. Sometimes in the initial phase, you do get the good fitting on fluorescent pattern, but when you do a topography, you see a pattern like this on the right hand side. You do not get a full ring pattern in initial phase. So do I need to wait for that pattern to come, or like it will be over a period of time it will come, or I can continue with that pattern?
Yes.
It takes time.
You should take more time to
It
get
is-
the
How much do you
pattern.
think it is
Yeah.
required?
It's almost about a month till you really get that kind of picture, you know.
Yes.
Initially,
Yes.
you will not have that kind of typical flattening picture. There'll be
Yes.
some changes, but if you do a central K manually also, that's where you'll have an estimate that these many diopters
Yeah.
in the center have
Right,
flattened.
right.
But the shape changes are not seen so early.
Yeah. Right.
So my question is, like, supposingly some part of the ring is left. Supposedly I'm seeing somewhere is not as steepened as that. So I can, on what basis I will say I'll continue with that?
It is usually that smiley face and that frown face.
Yeah.
If you find that kind of shape coming up, that means the lens fitting is behaving odd during the night
Yes.
while sleeping.
Yes.
So what we really look into that odd areas of a smiley and a frown face, and then only that tells us yes, the design and fit is not good. I think that is
yeah. Right.
your-
It's right.
Till how long the patient has to wear the ortho-K lens? Is there a time
in
limit for
fact,
it?
she's done lot more, but for us, till they have to wear orthokeratology throughout till they want the myopia control. So when they are adults, they can think of other options maybe when they can
Right.
come up.
Right.
And once they remove the lens and it's about 2-3 weeks or a month, it reversal comes back. So they can go back to spectacle anytime, they can go back to soft lenses. But if the intention is myopia control, and if you want myopia control, it has to be continuous. So
Yes.
it's forever till they want it.
Yeah.
What is the duration of wear of ortho-K lens during the sleep? Is there a minimum and
No,
a
no,
maximum
no,
for it?
no. There is no minimum duration of wearing in the sleep.
No.
Usually 8-10 hours of sleep is fine enough.
Yeah. Almostly, many people ask that question. So whenever they want to wear to do myopia control, they will continue the lenses, and some of people also don't understand about myopia, about the autokeratology. They thought that they will wear sometime and then myopia gone. That is not correct. So we have to explain more.
Yeah, so
to
if
the-
one starts with
Yeah.
the treatment purpose,
Yes.
it is till the growing age is there. So
Yeah.
they should be having it. And that
Yeah.
economics should be explained. It's not for today, it is for
Yeah.
at least 5-10
Yeah.
years that you have
Yeah.
to wear it.
When they are 25 or 8, they can discontinue the autokeratology, and then they will go for LASIK or refractive surgery.
Okay. Say,
No, in fact, the myopia, it's an alternative to vision correction. So suppose this
Yeah.
is -3 and ortho-K user, this will be plano in the morning,
Yes.
6x6.
Yes.
So when they discontinue ortho-K, they go back to -3.
Yeah.
So you remove the cornea shapes back to the original power, but at
Yeah.
least it has not progressed.
Yes.
I'm
Once a year replacements, annual replacement. It's the same cost. In rupees also now. So it's a little more expensive for our Indian patients. We are in a range of 30 to 40,000 a pair, and average life 1 to 1.5 year for a lens. It's because it's expensive because the number of patients which we do here are less. Once this becomes more popular, I think it will be easy to dictate and get the costings much lesser to our country, numbers that we can handle. So it's for the timing expensive. There are 3-4 big brands who are in the market who are playing it. Paragon was the one who initially started and they came into India. Paragon doesn't have a good setup link in India now, and today we have GOV, which Vikas is dealing, so you can directly talk to him for that business aspect. We have Euclid, which is again a US brand, which has been marketed through Essilor. So there are 2-3 brands only which are good and brand. Of course, there are some more smaller players, OK Vision and others, which are entering into it. And even Akshay may talk about it. So more and more companies are coming into it. For the timing, we have a network of 2-3 brands only. Yes, pair. To the patient, yes, care, maintenance and everything if you would count it. We only had one child who broke the lens within 1 month. Of course, the care is different from that RGP care. You use a little finger. We need peroxide systems, but we do not have it in India. So there was only one child, and within 1 month, if it broke, there was a replacement warranty. And the other child, it took almost 2 years when it broke down. So it's usually not seen, because you have to just wear it at night, sleep, and then wake up the first thing in the morning, wake up and remove it. So it's carefully kept in the containers and bad. Personally not. Only one girl, she had a breakage.
Ma'am, say if you have a case of moderate to high myopia, like -5, -6, does the ortho-K lens fully correct the refractive?
No, I experimented with one of my patients who was -6 with -1.52 diopter of cylinder. It was a little higher range. The mother and the child were very, very keen. They were from US, and so they knew about ortho-K, and they came to India to do it. I experimented with it. With the design that I had about 1.5 years back, I could not handle. There was residual cylinder and the visual acuity didn't come. But with GOV, we have lens up to, I think, -10.
Yeah.
They correct up to -10, and there are different designs for high myopes. So
Yes.
you've been doing, I think, high myopes
Yes,
quite often.
high myope. Highest myopia in my cases is 11. Yeah. Of
Should
course,
we-
with the high myopia, you have to have you need much time to gain the good vision. Yeah.
Should we counsel the patient that you might have to wear a small power glass?
See, second thing, which we didn't do it in our presentations in lens selection. Suppose the keratometry is initially only 40 diopters, and you have a -8 myope. How flat are you going to go? So you need a good E value of the cornea. That is very important in selection. So you pre-estimate if 43, 44, 45 diopters of cornea, it's very easy and they respond very well. We call them good responders. But if the K is like 38, 39, and there you are talking of flattening 7, 8 diopters, is going to be a problem.
Yeah. Right.
Okay, can I add some? Usually in high myopes, which I have done like few cases, so I prefer to go with the soft OK one.
Yeah.
Right, so that is there is no transition zone in the soft OK one. You get a good tear layer instead of the compression through the ortho-K lens. So soft OK lens works much better in higher powers, in high myopes.
In fact,
Right.
what we need
Right.
to now understand is there are variable options. So the child, if not, at least start talking to them to be outdoors. More outdoors, less digital work, at least start doing that kind of recommendation. The options are there. What we need to do is, even that OK Vision, which we have also started, it's the axial length which should be monitored. Each of the research paper only talks about the number being there where it was, but it's not the number. It's also the axial length growth which should be done. Atropine, one of the case that I saw, from -2, when the atropine was stopped, when rebounded to -7. And it was a bad case. This child is 11th class student now, and the accommodation anomalies or whatever we couldn't handle the kind of fluctuation this child had in vision. So options are available with us, but we'll be learning more and more as we come in India, our experiences. So documentation of axial length is very important if we have to really say myopia has been controlled.
Yeah. So that's your question that you want to ask me about soft OK lenses, right?
If you ask me a question, my question is, suppose I'm going for a prescription with -8 with -2 cylindrical.
Uh-huh.
So does or when I start
Yeah.
putting ortho-K lens on that patient, So how much time does it take to get the correction full? Because I have seen it takes really 1 week to 10 days.
Yeah.
So that is the time the patient has to be in the house. He cannot go outside. Or in the evening they have a lot of fluctuation in the vision.
Yeah.
So
That-
what exactly that 1 week or 10 days period that the patient has to do?
Yeah, that happens. For example, with GOV lenses, you can get better vision immediately in the first week. So my patient will have a vision without glasses in the daytime about 4